Thank you very much, and a very good afternoon to all of you. And I would like to thank the Society for giving me this opportunity to be talking to you about cardiac imaging. I just want to give you an update on the role of cardiac MR in today's practice. I will be talking about areas of guidelines, areas of how we do cardiac imaging, and where is the role of cardiac imaging in today's practice. The talk, I would like to make it a lot more case-based, so I'm going to show you different cases so you understand and realize the role of cardiac MR in day-to-day basis and some of the practical aspects of cardiac MR. As of now, cardiac MR is the gold standard for ventricular function and volumes. Echocardiography is the frontline investigation, but it is not very accurate and can make a lot of assumptions and errors. That's why cardiac MR is considered as the gold standard for that. When we talk about morphology, there is no comparison to what cardiac MR can do that is unparalleled in its assessment. And if a patient has cardiomyopathy, cardiac MR is a one-stop shop where you go and get one scan and it'll give you all the answers. You don't need to do multiple different examinations for these patients. And when we look at cardiac MR, this is what we get as part of cardiac MR. A full assessment of the heart from the base to the apex as part of the whole 3D volumetry. This makes it so useful and so unique that when you're looking at the heart, you're not going to miss any portion of the heart. When we look at patients who have funny shaped hearts, so for example, when you're looking at the heart across here, you can see there is a large aneurysm. And when you see this patient having an echocardiogram, it will not be able to assess the volumes accurately. That's where cardiac MR comes into big force. Again, looking at valvular assessment, where you can see there is significant mitral regurgitation and tricuspid regurgitation, cardiac MR is becoming as good as echocardiogram in assessment of these patients. There's a lot of trials. One of the most common things that we talk about is the value of cardiac function. And if you look at it, this study which looked at the STITCH trial as it's called, if LV ejection fraction on CMR was more than 30%, there was zero mortality, which is a very powerful indicator. So if you've got very good function on LV, on CMR, then the mortality is very low in these patients. Now, the power of MRI comes in this slide. This one slide actually summarizes the power of MR. If you have 4 different patients who come for an echocardiogram and you see that there is LV hypertrophy in all of these patients, echo will say that this is LV hypertrophy and that's a full stop. You will not know the diagnosis of these patients. With cardiac MR, it is possible to differentiate the different causes of LV hypertrophy. So we are able to say this is hypertrophic cardiomyopathy. We are able to say that this is Fabry's disease. We are able to say that it is amyloid. And that is done by what is called as late gadolinium enhancement imaging, whereby we give contrast and we wait for about 5 to 7 minutes and we do late gadolinium enhancement. And we look at different patterns of enhancement which allows us to differentiate ischemic from non-ischemic and different pathologies within ischemic. Now, if you look at any pathology, any cardiac pathology, this one sequence is very good when you look at a combined series of 23,000 patients. Every 1% increase in LGE, amount of enhancement, is associated with poor prognosis. Okay, so if you just do late gadolinium enhancement, you're able to prognosticate the patients much, much better than any other imaging. Let's look at some cases. This is a young female who's come in with shortness of breath, and tiredness over a few months. There was no chest pain. There was no other trigger factors. When you look at the cardiac MR of this patient, what you will see is that the heart is dilated and it's not contracting well at all. You can see there is almost no contractility of the ventricle. And when we look at delayed enhancement imaging, in delayed enhancement imaging, normal myocardium is black and abnormal myocardium has got areas of whiteness. This is a case of non-ischemic dilated cardiomyopathy. This is an idiopathic cardiomyopathy often seen in young people. And what is the role of cardiac MR? 30% of these patients will have mid-myocardial enhancement, which is what we just saw. If you have mid-myocardial enhancement, you are twice likely to die from it. Okay, so it's a very poor prognostic feature, so that's very important. You're more likely to have arrhythmia, which makes life harder as well. And when we looked at our own data set, this is a data set of around 1,500 odd patients, what you will see is there is late gadolinium enhancement in itself has a very, very poor prognostic indicator along with T1 mapping, T1 values of the myocardium, and we can easily see that the prognosis keeps worsening as the time goes on. By about 8th year, the mortality is very high. Nearly 50% of these patients do not survive. So it's very important to be aware of this. If you look at patients who have DCM, what you will see across everyone, that patients who have a follow-up with cardiac MR, we are able to better risk stratify them. So you have patients with dilated cardiomyopathy, you prognosticate them, you follow them up in 6 months' time, and if the parameters are improving, they are likely to do better. If it is not improving, then you need to start thinking in terms of other therapies like transplant or replacement therapies. Let's look at another young female, a 38-year-old female who kept having recurrent admissions. She would come in with heart failure. We'll treat her, she will get better. Again, after 6 months, she'll come back with heart failure. This is something very, very unusual case. It took us some time to get to the bottom because cardiac MR was never asked for. Angio was normal, no drug intake, and this was the cardiac MR. Now, here, if you see, the heart is functioning slightly better compared to what we saw in the last case. And if you see across here, in delayed enhancement imaging, there is no enhancement. So the clue to the diagnosis is in the image, and people who do not do cardiac imaging also may be able to see. Look at the liver. Look at the liver of this patient, compare it to the spleen. So if you see across here, at the bottom, this is the spleen, nice and bright. You see the liver, which is very dark in this patient. And when you look at, this is the normal liver, and this is what the liver looks like in this patient. In the same way, if we look at the myocardium, this is normal myocardium. This is how dark it looks. This is iron overload cardiomyopathy. This is a patient who had recurrent blood transfusions. Nobody connected these two things together. She was a thalassemia patient, and this led to her LV dysfunction. T2 star is a methodology which we use to estimate the iron overload, and when we are able to estimate both hepatic as well as myocardial iron overload, we can start chelation therapy, and this significantly improves the prognosis in these patients. A different patient, a 56-year-old patient who came in with chest pain, normal CT coronary angiography. So I've got two scans for the same patient. I'm going to show you both of them together so you understand what you're looking at. And this is what happens. The top row is the initial presentation. The bottom row is the patient after 6 months. Look at this image here and this image here. This is edema imaging, and this is delayed enhancement imaging. 6 months later, the whole area gets resolved. This was a case of acute myocarditis that the patient had presented with, and it resolved in 6 months' time. So those of you who do not do cardiac imaging, there is this term called MINOCA, myocardial infarction in non-occlusive coronary arteries. So patients come in with chest pain, cardiac enzymes are elevated, you take them for an angio and the angio is normal. So they have myocardial infarction but normal coronary angio. And cardiac MR manages to reclassify 78% of these patients. So a lot of patients have myocarditis. A lot of patients also have Takotsubo cardiomyopathy, which is stress cardiomyopathy. And with cardiac MR, we are able to differentiate these. And people who do not have any of these, again, have very poor outcome. So you can see across here, outcome in other patients is very high. The same way we've seen that if you do early cardiac MR in these patients, the prognosis is much, much better. You can tend to get early recovery of these patients. You can see across here, these patients do much better if you do cardiac MR early in this journey. So patients who come in with myocardial infarction, normal coronaries, cardiac MR is the gold standard. Very recently, as early as last week, the guidelines for management of myocarditis have changed, and cardiac MR has become a class 1B indication for doing this. So patients who are suspected to have myocarditis, in past, you needed biopsies. Now, cardiac MR is sufficient to make that diagnosis. Let's look at a different case. This was a patient who came in with LV dysfunction. ECG showed heart block. The coronaries were normal. And this is the cardiac MR. And what is important to see in this patient will be, look at the area of the septum, which doesn't seem to be contracting as well as the other areas of the septum. So this is, and when we do delayed enhancement imaging, you can see areas of, focal areas of enhancement, multiple patchy areas of enhancement. This is cardiac sarcoidosis. Cardiac sarcoidosis is something very, very important to pick, and cardiac MR is very good at picking up these patients. Nearly 20% of patients with lung sarcoid will have cardiac sarcoid. In some cases, they first present with cardiac involvement and then comes in the other manifestations. Late gadolinium enhancement is extremely good in stratifying these patients as to what is likely to happen. Another case, this is a patient who we often hear in news, 45-year-old male who had a syncope, and there is a family history of sudden cardiac death. These are usually sports persons who are playing some football or some other sports, and they drop while they are playing at stress. And what you're looking at here is this area of the myocardium, where you can see that there is obstruction to the left ventricular outflow tract. And when we look at the delayed enhancement of these patients, you will see these areas of, patchy areas of enhancement in the myocardium. This is a patient with hypertrophic obstructive cardiomyopathy. HOCM is a disease which is associated with poor prognosis, especially if you get more delayed enhancement. If patient has more than 15% of myocardial enhancement, then they are likely to have syncope, ventricular arrhythmias, and they are likely to die. So it's very important that cardiac MR is used for risk stratification. Very common nowadays in our practice is to assess patients who have coronary artery disease. This is a patient who's got severe double vessel disease, LAD and RCA. And what you can see across here is that this is, whole myocardium is thinned out. When you go and do any surgery in these patients, when you look at the delayed enhancement, what you will see is that this whole area, which is the LAD territory, is non-viable. It is dead. So there is no logic in going and putting a stent or bypass for that region. So you would only do procedure for the right coronary artery. So this is extremely useful in day-to-day practice and has become one of the most common indicator. Another important thing that people have to realize is if you see these two different patients, this is a patient who's come in with acute myocardial infarction, and this is edema imaging, and you can see there is diffuse edema in the myocardium, very similar to the brain penumbra that you see in there, and we can tell which area is infarcted and which area is at risk. Another important thing which becomes useful, this is a different patient. What you will see is this whole area has got bright and then black spots within it. This is intramyocardial hemorrhage with microvascular obstruction. This is a patient who usually die in the acute period with myocardial infarction. So cardiac MR can really prognosticate these patients at a very high level, giving us information. So the scar quantification of the LGE really helps in these patients. And also cardiac MR is extremely good when we look at early phase. We can tell if there is any areas of microvascular obstruction or intramyocardial hematomas. And then over a period of time, whether the left ventricle will remodel itself in the right manner or not, and what is going to be the outcome of these patients is very clear. Case number 9, this is a patient who had a 55-year-old male. He has RCA territory disease, okay? He has RCA territory disease. It was very clear that the myocardium was dead, but he was having recurrent ventricular tachycardias. So the question to us was, why is he got this recurrent ventricular tachycardia? And this is an interesting disease entity that one should know about. And you can see this is all myocardial infarct that we clearly can see. But if you look at the right ventricle here, you will see that the right ventricle has a wavy outline. It's not contracting normally. This disease entity, you can see a different patient where the right ventricle isn't contracting as well as the left ventricle. This is called as the arrhythmogenic right ventricular cardiomyopathy, or ARVC. This is the second most cause of sudden cardiac death in young people. So cardiac MR can differentiate ischemic, non-ischemic in the same patient. And what is very, very important, this one slide tells you, if you have a patient who has non-ischemic cardiomyopathy, a patient who has non-ischemic cardiomyopathy, MR can help you in giving so much information which will help you in making the diagnosis, knowing the prognosis, and how the patient is managed going ahead. I come from a center. We are based out of south of India. I trained in Cambridge. I was in the UK system for 15 years. And we've brought in these best practices to India. We perform about 150 cardiac CTs every day and about 15 to 20 cardiac MRs every day. And this has led to a significant growth and improved outcome of our patients. And I would wish that you're able to do this. This is my last case. This is a 45-year-old female who's come in with breathlessness. And on echo, they were able to find this focal abnormality, which is in the right atrium, and it is prolapsing into the right ventricle. Now, what you will see, this is how it looks on cardiac MR. The lesion, which is in the right atrium, keeps going into the right ventricle every beat and then comes back out. This is a CT scan. And when you look at the CT scan, you can see this lesion in the IVC. It is all in the IVC. It's keeping on coming down further. And you can see across here, it comes off. This is into the gonadal veins. And you can see there's this large tumor which is coming from the pelvis, which is all the way projected into the right heart. And cardiac MR is able to give you that information all together in this patient, which makes life so much easier for us to make that diagnosis. A lot of people talk about cardiac MR takes too much scan time. When you're starting to do cardiac MR, it may take up to 2 hours. There are these new protocols which are able to do scans in 30 minutes. In 30 minutes, and this is very, very good, where you are able to get all the information in these patients, and it doesn't take that much time. You get the functional analysis, you can even do perfusion imaging for ischemia, and then you can do delayed enhancement. And it is feasible to do cardiac MR in 30 minutes. So it's very important that we adopt cardiac MR. A lot of areas where we can contribute to patients' outcome in this. So, in summary, cardiac MR is becoming, well, it is the gold standard for assessment of cardiac volumes, cardiac function. Cardiac MR is excellent in assessment of the anatomy. It provides a great information when it comes to making diagnosis of different cardiomyopathies. It is also able to give you a lot of prognostic information which may not be available in any other imaging modalities. It is able to quantify the blood flow from one direction to the other direction, how much blood is flowing through a congenital heart defect that we can look at. And it is feasible to do these examinations now within 30 minutes in there. So thank you very much for having me and your patient listening.